Okay, everybody, welcome to this Mind the Gap project webinar as part of the Commitments to Carers programme. My name is Neil Churchill. I am the Director for Experience, Participation and Equalities, NHS England, NHS Improvement, part of the NHS Commitments to Carers programme. And delighted to be here today looking at the Mind the Gap work, which is partly a learning event from the phase one projects that have completed, but also the launch of the next phase of the work. So I'm really pleased to see so many of you here today for the discussion. So I'm just going to give just a few words of context. We all know that unpaid carers have a double jeopardy, really, in that we know that their own health is poorer than for non-carers, whether that's in terms of physical health or in terms of mental health. We know that from things like the General Practice Patient Survey and the State of Caring report. And we also know that within that some communities have greater disparity than others, possibly because of vulnerabilities in those communities or other forms of marginalisation or discrimination. So it's always been an important part of the NHS Commitments to Carers programme that we focus projects on what we can learn and what we can do to deal with some of that double jeopardy and to support some of those carers from vulnerable, marginalised or communities experiencing discrimination. And important and interesting as well to recognise that PHE has recently recognised caring as a social determinant of health in its own right. And I know there's a lot of interest in carers charities in looking at caring as a protected characteristic. I know that's something that some systems already do. So the goal of today is to look at some of the learnings we've seen from the phase one work. I was privileged to be part of that launch event, and it was very clear that the work that people were proposing to do was meeting important needs, and it was also really clear that it had much wider implications, and there was a lot of interest amongst the participants about sharing and learning from each other, and we're absolutely clear and determined that we want to spread and encourage some of those learnings into wider organisations and including into NHS England. So part of the goal today is to share the learning from last year's projects, but also we're launching the next phase and inviting new sites to bid to be part of the work looking forward. So it's going to be quite an exciting afternoon. Just a little bit of housekeeping. I know people have been introducing yourself in the chat, but please do, if you haven't already, just say who you are and where you're from. That would be really helpful. Please do use the chat box to ask any questions or make any comments. We will endeavour to answer those questions or address those comments in the course of this afternoon. But if we don't get time, we are going to get back to everybody and we'll follow up with a response to what people have been saying. And if you are tweeting today's session, and given that this is about spreading learning, tweeting is encouraged, please do use hashtags either hashtag NHS Think Carer or hashtag Mind the Gap, or potentially both of those hashtags. So that's an introduction from me. I'm going to hand over now to Verity for an introduction to the afternoon.
So next we have, thank you very much, Neil, for that overview. Next we have Jen, who's going to be speaking about the purpose of the work. So I'll hand over to Jen.
Thanks, Verity. So thank you all so much for joining this afternoon. I appreciate it's a really busy time of year when we're all starting to try and get back to some sort of normal working as usual as we're hopefully coming to the back ends of the pandemic, but obviously being mindful that the pressures are still very much there. So I get the nice bit of saying a little bit about why these projects are so important. And I just wanted to start by just reflecting firstly on the title of Mind the Gap. And the reason we picked it was it's one of those phrases that you hear all the time, but it becomes a bit like white noise. So you get on and off a tube train and you kind of know you should be careful about something, but you don't really pay attention anymore. And we kind of feel that in a lot of ways, some of the equalities issues that we've addressed through the work that's been done so far and that we're identifying as the work goes forward are the things that people have become a bit comfortably blind to. And actually, it's one of those things that we really need to start minding, because actually, if we don't mind the gap it then becomes a real problem and a risk to people and their health. So the aims of the projects that we've got coming forward are really around trying to better understand how carers from often excluded groups, so potentially really vulnerable communities, are actually identified and engaged and supported. Neil's already mentioned the poorer health of carers versus non-carers. And actually, as you start to look at it in the context of inequalities, you really do start to see an intersectionality of issues where actually being a carer will impact on your health, but also being from an ethnic minority and being a carer will impact on your health even more. You add into that gender, sexuality, and the problems become sort of significantly larger. So the long-term plan aims were very much around how do we tackle this in a really proactive way that puts integrated care systems in a leadership role, but in a leadership role that's very much a partnership with those communities, with voluntary sector organisations, and importantly also with the local authority as well. So it's really about understanding more, taking time to listen, acting in a way that's actually going to be productive for those communities rather than assuming, and ensuring that co-design is at the absolute heart of the work that's being done. And when we're doing this work with communities, we're thinking about not just how we implement change locally, but actually how those things are sustained, how they might be scalable, spread across different localities, and we can see a real national impact on the work that's being done. And importantly, how we evaluate that's happening, so that we have carers and those communities at the heart of the evaluation process, actually saying if things have worked for them and what we might need to do differently going forward. Next slide, please. So I guess we've already sort of mentioned we have two phases this year. One is almost a repeat of last year where we're recruiting a new set of project cohorts, but also what we want to do is look at the embedding process. So having done scoping work to understand what needs to change, actually then how do we make sure that change is embedded and driven within communities? So how do we put in place the interventions that were identified over the last year so that carers actually start to realise a real benefit to changes, and they can see that those benefits are going to stay there and not just disappear after a while? And also, how do we share that evaluation so that we know what's worked and also what doesn't happen? So I've just seen someone say co-production, not co-design. Absolutely. We use lots of phrases interchangeably, and I'm very happy to switch to co-production. I know it has a different meaning, but yeah, we are talking about this being shared working, shared learning, and bringing stuff together. Thanks. Can I have the next slide, please? So this is all around collaboration. So there was a very clear vision within the NHS long-term plan that we didn't want carers to feel left alone and that the NHS wasn't there to support them. But we also realise that that can't happen with one organisation acting on its own. It does have to be a collaborative effort. It does have to be about co-production, and it's about how we then deliver that in a really productive way. So it's making sure that when we offer funding to organisations, to ICS localities, that it's about them also thinking what they put into it as well, that they absolutely participate in the bid process in the spirit that it's meant as a piece of co-production. So they are participating in partnership, as I said, with local authority, with the voluntary sector, and with carers themselves and those communities that they want to try and do a better job for. We do set out some mandatory criteria for those bids, and Verity will be updating on that later. And there are also next steps to all of this, in that it's not just have some money, go away and do a project. It's about how do we make this a really dynamic learning process between those communities, the ICS localities, and the wider NHS community, and our wider carers community as well. So it's about sharing, making sure that we keep building on the projects that we run year on year, and also making sure that we absolutely embed the work that goes forward. Next slide, please. So you'll see that they are obviously the protected characteristic groups that everyone's really familiar with in terms of equality and diversity work. And I think what has come out really strongly through the last lot of projects is that the intersectionality between these really matters as well, and understanding that most people aren't just one thing. So really important that we bear that in mind, and also think about some of those communities that don't necessarily fit directly into these groups as well. And some of those that have come up very much to us from communities we've been working with over the last few years have been people with alcohol and substance abuse, addiction, people from armed forces communities, and some of the migrant and asylum seeking and refugee communities as well. Next slide, please. So I think this is really important, that you can do all sorts of work and put money in all sorts of different places, but it's the feedback from the people that you're working with that really matters, that helps develop that understanding. And you've got some quotes there from a number of people who talk about some of the cultural issues around language and how some things don't translate. So we might talk about mental health, for instance, in one way, but actually in another community, that's not how they refer to it or how they're comfortable with it. How people are comfortable culturally with different staff members from different organisations dealing with them. Thinking about how people acknowledge and deal with and respect who that person is as an individual as well. But I think really important that the words of carers are absolutely at the heart of what we do, and that they drive what we do as well. Next slide, please. Oh, so I think that was me. So I think just to sort of round off what I was saying, that this is very much an integrated care system led programme of work that is absolutely dependent on those groups coming together in partnership, that it isn't about people doing things solo, it's about having a collaborative co-production approach, and then seeing actually if what we're doing is exactly what communities want. So I'll hand back to Verity. Thanks.
Thank you, Jen. And to illustrate that point, I'm hoping that we have Christy on the line, who's from the east of England and was part of one of the projects that was successful last year for Mind the Gap. And Christy cares for her son David, who has sickle cell anemia, and she's going to talk to us a little bit about the difference the project has made to her as a carer. So I'll hand over to you, Christy, if you're there.
Oh, sorry. Hello. My name is Christy. Can you hear me?
Hello.
Yes.
Yeah. Oh, okay. Yeah, my name is Christy. I'm a carer for my 9-year-old son, soon to be 10 in September, David. The project has really helped a lot because I've been wanting to join a support group, which I have with the one in London, but because it's too far, so it's been difficult for me to really attend their meetings until now. With COVID, we can do it on Zoom, so that's been helpful. So once the project has started, we've had about 5 or 6 regular meetings, normally on Saturdays, but we've changed it now to Friday evenings. Now we have it like every 2-3 weeks. And I try to lead it, or I get some of the carers to help me lead it. So it's been helpful, and we've shared ideas on how we treat the kids, and when they're in crisis, how we get to keep the pain in control. And we've made new friends as well. So it's been really helpful for me, I must say, and hopefully to continue to be that way as well. Is there any questions?
Lots of applause for you, Christy. I think Verity is having trouble unmuting at the moment. Steve, do you want to go to the... We'll step in for Verity, Steve.
I'm back. It's managed to unmute now.
Okay.
Thank you very much, Christy. And I think that you found, haven't you, that some of the things that were most helpful was actually the informal opportunity to meet. And I think I remember Jodie saying that it started as one thing and it evolved into another based on the feedback that you'd given in terms of what you all wanted from a group.
Yes.
I don't know if you want to say a little bit more about that.
What I wanted from the group was really support and ideas from the other parents and how they handle this whole situation of caring for a sick child with sickle cell. So it's been the same experience really, especially in hospitals, how they feel they're treated or how they feel they should be treated in hospital. Recently, we actually had a meeting, but with the London team, with the Sickle Cell Society. They wanted to know what we as parents or carers and the patients wanted to see improve in hospitals and with the professionals. So we made a list of the different things and experience we've had in hospitals and what we expect to be changed in the near future. The main point was people felt the illness was not widely understood or there wasn't much awareness of what sickle cell is. So the parents and even the patients, some of them were adult patients, they felt frustrated and they felt more training provided to the NHS staff, especially with the A&E staff, to be aware of what sickle cell is and how to treat it. And also the idea of having a care plan on the hospitals. So when we go to the hospitals, they can just take the care plan and see how to treat the patient. Because sometimes the patient is there by themselves and they're a bit frustrated because they cannot really tell them what they need. But by looking into the care plan, they could see their regular treatment or what they need. So that was the main things we discussed, and also more awareness.
Thank you, Christy, for sharing that. And I'm really glad that through the project you've been able to influence NHS kind of the decision making and improving things for carers who are caring for those with sickle cell. Yes. So the next thing we're going to do is go into breakout rooms. The other thing, so Carlina has just said in the chat, it'd be interesting to see the report when they're available. So all of the case studies are available on our NHS Futures platform from all of the projects. So we're going to go into breakout rooms now, and everyone is going to be automatically assigned. So it'll give you a flavour of the project. But as I say, case studies for all the projects will be on the Futures platform. And if you email our generic email, which will be in the slides when we share them, you will be able to ask for access to those case studies. The other thing to ask you to do is if you please could stay in your rooms during the break, that would be wonderful. We're going to keep you in the same room, have a break, and then hear from the next project. So everyone will have the opportunity to hear from 4 projects, and then you will be automatically brought to the main room to hear from the external evaluators and BOLA regarding kind of the health inequalities agenda. So I will leave Steve to the magic of putting us all in our rooms.
Hi everyone, you should get notification on your screen to say in 10 seconds you will be transferred to your breakout rooms. Just bear with me. So for those staying in this room, we have Jodie leading chair in the first session. So Jodie, are you on? You're on mute, Jodie. There you go. Hi, Jodie. You can start now. You can introduce the next group.
While Jodie's absent, is Christy still here that just spoke? Kara?
Yeah, I'm still here.
Hi, Christy. Thanks for raising the issues around sickle cell. I'm from Healthwatch Sandwell, and I work with people with sickle cell. And I agree with you, there's not enough awareness of the condition. Yeah. And certainly in our area, the services for healthcare are not joined up working. So I think people really need to hear what you've said and take that on board. So thanks for sharing.
Thank you. I think I'm finally unmuted. So my name's Jodie. I'm the carers lead for the East of England, and welcome to the session. Just to remind you that this session will be recorded and we're going to keep everybody on mute. Any questions, if you could put them.
You're on mute again, Jodie.
Help!
Yeah, we can hear you.
Oh, can you? Thank you.
Again, you've got to mute.
Okay. So just to remind everybody that all the case studies will be on the NHS Futures platform. So if you don't have access to that, please email the NHS Think Carer email address and we'll send you an invite. So we are on a really, really strict time limit. So each presentation will only be 10 minutes. If you do go over, we will have to stop you. So I do apologise in advance. And it's because we are really tight and we want to ensure that all these 4 presentations are heard. So our very first presentation to kick off is from the South Tees region. So if Beth, Lee and Tim can unmute themselves, they have done a project transitioning from young carer to adult carer services. And your 10 minutes starts as soon as you talk.
Good afternoon. My name's Lee O'Brien. I'm Chief Executive of Carers Together, and I'm here with my colleague Beth. I don't know if you want to introduce yourself, Beth.
Hiya, Beth Major. I'm the Chief Executive of the Junction Foundation, which is the kind of young carers deliverer for South Tees.
Okay, so obviously for the next 10 minutes, we'll run you quickly through our Man the Gap project, which really was around working with young adult carers who were transitioning from children's services into adult sort of support, really. Can I have the next slide, please? So why young adult carers? Our initial thought, I mean, Beth and I have been working with young carers and adult carers for a while now, and we've kind of noticed that there's been a bit of a disengagement from services with young carers when they hit about 14, 15, and they tend to reappear in adult services at about 25. So we know there's this kind of hidden cohort of carers between that age that kind of fall off the radar, I guess. We know that there's also a disconnect really between children and adult services, and transitioning for anybody who's within services is difficult. But if you're transitioning from children's to adults or from secondary education into higher education or further education. There's always this kind of transitional issue. So we know that, and we've seen a lot of this really about the systemic issues around transitions. We also, Beth and I have also worked looking for data on the needs of this cohort of carers between 15 and 25, and there is quite a significant lack of data really. So part of this work was to obviously to inform national and regional strategy, again, regional local strategy around the needs of young adult carers. And also it was a really good opportunity for the Junction, which is obviously, as Beth alluded to, the statutory, well, the commission provider in South Tees for young carers, and Carers Together, who are the commission provider for adult carers in South Tees, to get together with young adult carers. So we were able to bring young carers and adult carers together from both organisations really to have a look at needs. Can I have the next question, the next slide, please? So the question we asked overall really was, what would help young adult carers to make a successful transition to adulthood? So that was the kind of the foundations of our work. Can I have the next slide, please? I am racing through this obviously because of the time issue. So we kind of went to this cohort of young adult carers, and we used what was called a participatory appraisal process. So we were able to engage with these young adult carers 15 to 25 in individual discussions first, using an appreciative inquiry. So we looked at the discovery stage. We wanted to know what would work, what works or would work for young adult carers in supporting them as they go through this transition stage. We also had what was called a dream stage of consultation, which was around what could be better. And then the design stage was around, like say, what would make young adults carers suggestions a reality. So we're kind of at that point now, really, about the reality, I guess. These responses were then used on the basis of a consultation with other young adult carers. So I think, as Beth will allude to later on, the actual plan was that we would do this consultation with a small number of young adult carers, and then we would roll it out more widely with other young adults. But there was an issue around COVID, and Beth will explain that. So then we get to the final stage where we got to this destiny stage now. So we're in the kind of the design and destiny stage, I guess, where we're looking at implementing these young adult carers suggestions. So that's where we are now. Can I have the next slide, please? So phase one, the results. We consulted quite intensively really with 12 young adult carers from across South Tees. So that, for those of you who don't know, that's Middlesbrough and Redcar and Cleveland. 4 male, 8 female. There was an even spread across the postcodes, and we were looking for representation from some of our most deprived wards. Within the South Tees area, we have quite a number of wards that are up there in the top 5%. Some are in the top 2 and 1% of the most deprived wards in the country. So we were able to consult with these young adults in them deprived wards. As you can see there was 2 young carers, and they were involved in caring for parents. 1 was looking after the grandparent. 3 was caring for siblings, and 2 were caring for both the parents and the siblings. Can I have the next slide, please? So, sorry, can you just go back one for me? That's great. So what went well? Well, firstly, we were able to really get young adult carers involved in this consultation, in this project, both during and presenting the findings. They've actually been online and spoke about the in these meetings, I think, and have spoke about some of the issues they have. It was good because we had already had existing relationships with some of these young adults, and they felt that they trusted us. We were able also to involve young adult carers and offer support. As we went through consultation, it became quite obvious that there was some emergent support needs that we could address pretty much straight away, getting people online, getting people where they needed to be. So both the Junction and Carers Together could work really closely with those young adults to issue immediate support to them. And I think also from both the Junction and Carers Together's point of view, we were able to add some value to this project, we feel, as in the amount of time that we spent, how we brought our expertise to the project, and the commitment from both organisations, which really brings us on to point 4. The partnership working went well, as in we've had to bring 2 relatively large charities across the South East together to work to look at these options. So Beth and I have worked really closely and kept in regular contact, looking at options for us to move forward in partnership. Okay, I can now hand over to Beth, please.
Next slide, Steve. Thanks. So what we do differently, I mean, obviously the timing of the project was particularly challenging in that we kind of were in full lockdown mode, and 75% of the young carers who initially said we want to be involved in the kind of dream stage and the individual interviews opted for face-to-face meetings initially, but that wasn't possible due to the timing of the project, really. And online and telephone options were not appropriate for some young adult carers, you know, things like lack of privacy in the home, lack of mobile phones, etc., etc. So I think in terms of learning, and this was at a stage where we hadn't necessarily gotten fully mobilised around digital inclusion within services. So I think, you know, what we do differently is not do it during a pandemic. Both charities had to consider subcontracting arrangements, safeguarding arrangements and data sharing arrangements. And it was a significant piece of work that I think we kind of hadn't built into the project's time scale. And I would say that, you know, in terms of bringing organisations together in a way where we are accessing a lot of personal sensitive data, if anybody's considering doing something similarly, build that time into the project time scale, really. The final stage of the participatory appraisal process also should have involved a kind of get mass participation and interactive group work, which is very much kind of all the ideas in, stick it on a post-it note, put it on a wall, and very, very interactive and participative. And because we weren't able to do that in person, we had to replace that stage with a survey, which may have reduced the number of respondents, although we did get a reasonably good amount of responses, but it possibly affected the quality of data, because I think when you're in person and you can have those kind of discussions, that enriches the information that you can get back. So, and I don't know how we build the level of disruption we had in that last year into future planning, but I think we've all learned that we always need a plan B. Next slide, please. So what did young adult carers say that they would help support and improve their transition into adulthood? In a nutshell, there was lots of individual recommendations that we worked with young people to rank, but essentially they wanted a specific project for young adult carers aged 15 to 25 who have shared experiences of living through a range of transitions between services and moving into adulthood. They didn't feel that kind of composite part was really good. It was really good enough, and what they wanted to see was their own service. Next slide, please. In terms of some of the composite parts of that service, they wanted to see work with education, health and social care services to identify young adult carers, PSHE lessons for school pupils about the role of young carers and the impact. And that was both in terms of kind of identifying hidden young carers and in terms of kind of highlighting maybe some of the support needs for peers. Developing and delivering life skills sessions and kind of that change in expectations that goes with transitions. Young carers transition passports was ranked joint third. delivering training about young adult carers and the impact of the care and role for professionals in education, health and social care services, specialist transition link workers who have maybe that information, advice, guidance and that awareness of young carers issues, and providing a range of age-specific information and support services, because they did feel like there was a gap between child-focused services and adult-focused services. Next slide, please. The benefits of taking part in the project overall were around the opportunity for co-production and partnership work, and the young people got a lot out of the process as well. They're not here today, but we have had young people presenting their findings in lots of local settings and lots of national settings. It's about their availability today. Ability to bring in an independent facilitator, and we felt that that was really important and needed to be resourced, so young people felt that.
Excuse me, sorry Beth, I am going to have to call it round it up. Do you have a final couple of words, because it is a really interesting project and I feel really bad, sorry.
No, it's absolutely fine, I get it. You're put in this position of chair and you need to chair.
I think what makes it more pressured is that when they're all finished, the presentations, we will be ending automatically, so we don't have that choice to go over time. We will be cut, and so we just want to make sure that the last presentation still gets that time. So thank you everybody, that was really good. I have put in the chat box the NHS email address for people to get access to the Futures platform, and then can get access to all the presentations. So our next presentation is from the London region, and we've got Colin and Charmaine and also Tom, who will be doing the presentations for this. So thank you.
Hi there. Hi everybody. Colin Powell speaking. Hi. So welcome. Our project was focusing on unpaid carers who may have been existing refugees and or asylum seekers. So just very quickly, what is a refugee? According to the UN Refugee Convention, the definition of a refugee is someone who, owing to a well-founded fear of being persecuted for reasons of race, religion, nationality, membership of a particular social group or political opinion, is outside the country of his nationality and is unable to, or owing to such fear, is unwilling to avail himself of the protection of that country. And that's Article 1, 1951 Convention relating to the status of refugees. Now, just very quickly, what is an asylum seeker? The definition of an asylum seeker is someone who has arrived in a country and asked for asylum. Until they receive a decision as to whether or not they are a refugee, they are known as an asylum seeker. In the UK, this means they do not have the same rights as a refugee or a British citizen would. For example, people seeking asylum aren't allowed to work. So obviously I'm from Harrow Carers, I'm the operations director. It was really interesting for us in terms of our research. Unfortunately, our research worker who was only employed 3 months, Mr. Armando Conte, can't be with us today, but he carried out some fantastic work in terms of collaborating with an organisation called HASVO, which is our local Somalian voluntary organisation. And so we had a fantastic relationship with them. They assisted us to get 42 questionnaires returned as to unpaid carer, refugee and asylum seekers and what sorts of issues they were actually going through. So the results were really interesting and kind of led us to actually confer with ourselves and with others that there were refugees and asylum seekers that exist within the borough of Harrow. And the demographics of the 2011 census were very much out of date. We also know that there were a number of communities who may not fall within the old census and new census as well, as just recently carried out. And so therefore, they're kind of undocumented refugees who are in the country at this moment in time. So places an extra kind of question and ask, where are these individuals, are they getting the right support in terms of their health, which obviously we know that if they are a carer also and they've been fleeing from some very difficult circumstances and caring for others, there is almost like a treble, quadruple impact on their own health, which we have discovered. So that's just a very brief introduction. Can I move on to the next slide, please? Thank you very much. Just in terms of some stats here for you, if you just want to just have a quick skim through and read those. But what I will do is just go back to UNHCR, United Nations. And where do asylum seekers in the UK come from? Among adults, Iran was the top nationality claiming asylum in the UK in the year ending September 2022. The top 5 countries of nationality for asylum applications from main applicants were Iran, Albania, Iraq, and Eritrea. We also know from our own particular findings that there are undocumented, unregistered refugees as well. And we know that, for instance, in the borough of Harrow, there's 5,000 Kuwaitis, for instance, who are seeking support services. And we know from our survey returns that some of those individuals are unpaid carers and are in need of support. So just moving on from this slide, please. So part of our research, which we found out very, very early on, was about establishing trust. If you do not establish trust and say what you're going to do and include organizations within what you're trying to reach out to do and listen to what they have to say and listen with intent as well, because there could be certain messages in terms of translation that we could potentially miss. So, for instance, when we first started the project, we reached out, for instance, to HASVO, our Somalian organisation within the borough, and there are 15,000 Somalians that are living within Harrow itself at this moment in time. And we said that, you know, we're looking for hidden care, unpaid carer, refugee and asylum seekers. And instantly they said to us that the word hidden was a negative. And it was a negative because hidden says to people who have come to the country that they may be hiding for reasons that they shouldn't be here, they're not allowed here, they've done something wrong. So we quickly listened to that and we removed that title and just went to unpaid carer, refugee and asylum seekers, not hidden. And so how did we continue to try and reach out? And again, that was establishing trust, and it was listening to the conversations that were coming forward to us, because we've got to understand that certain people may be coming from areas of persecution. There is post-traumatic stress involved, which we found out also. And to have a friendly voice that listens is really, really important. Moving through to the next slide, please. I'm going to rush through so we keep on time. So we know that I've kind of jumped forward a little bit in terms of what we did. And we know the way forward is collaboration. It is about working together. And in collaboration and working together, it's a shared and equal power dynamic, which is really, really important, because we know that certain communities, that they face racism, they face Islamophobia, for instance, and we know that a large number of those refugees and asylum seekers within our borough are actually Arabic speakers, and they could also be Muslims as well. So to have on board and have those voices on board is so important for us, and to work on an equal basis, which we're planning to do moving forward, and which we touched on in the first phase of our project. Moving on, please. So these are some of the organisations, obviously Harrow Association for Somali Voluntary Organisations, PIWAND, which is an Afghani Association of West London, Harrow Council, which we reached out to also as well in terms of support to try and find out about refugees and asylum seekers, of which their business intelligence unit couldn't actually help us upon. And so we went out to other organisations to find out where people were and why they weren't coming to us in terms of Harrow carers. So from that kind of work, what we found out was that language was really important. Trusted faces are really important. So people who may look like me is usually where people will go to or associate with to go out and gain that support. So building that trust and building yourself as part of that universal trusted picture is really important. Moving on to the next slide, please. So how are we going to collaborate? Well, obviously, we've got to look at the whats, the whys, the whos, the wheres, the hows, and the whens as part of that planning as we move forward. So within our collaboration, these organisations and also carers will be part of all of our next phase. Fingers crossed that we'll get the funding for that. So we will be asking certain questions, but what we will do is have people from those communities asking those questions and leading on sessions as well. So having that buy-in, having that collaborative approach is really important for us. Next slide, please. Collaborative services, listening to community voices that are often masked. So there's a slight bit of a pun there with the mask because of COVID, etc. But we know that communities are often masked because of certain reasons. And I mentioned those a little bit earlier in terms of racism, in terms of Islamophobia, in terms of trust, maybe in terms of misunderstanding, not knowing how to communicate with people. It might be that people's voices are masked because they don't understand the content of written formats, for instance, and how do we translate those written formats so people can rightfully apply for what in terms of what we offer and what other services offer, GPs, NHS services, everybody, in terms of having that access to services for our client group. Moving forward. Seeking approval, sowing seeds. Seeking approval is really important. So seeking approval is also part of that trust dynamic. And it is about seeking approval. It's really important about the language that is used as well. And it is about, you know, you have to very carefully think about the words that you use. I mentioned the example of using the word hidden carer and the negative connotations around that. So when you do meet with people, when we have met with the particular organisations and client groups, language is really important. And also paying due respect to people's own cultural values as well. As part of that, it's trying to also understand, which we found out very early on, that there are differences in methods and modes of communication and how cultures communicate. And we know that, for instance, the Somali community very much communicate via the spoken word. So the spoken word was really important to understand. And that was very new for me. It was very new for our research worker as well, who had carried out various research projects across the world. So listening to the spoken word and communicating by the spoken word is very important. Seeking approval is highly important. Moving on, a couple more slides to go and we're nearly there. So I suppose we're looking at collaboration here and, you know, looking at the future collaboration of how we're going to do it. Teamwork, trust, inspiration, exchange, assist, support, share, collaborate. Also in there, I'd also like to throw in there that the use of language and how we do communicate, the words that we use are so important to gain that trust. Moving on. Services established. Once we've been through our collaborative plan, we've done our appropriate marketing, we've pulled everybody into that plan, then we've developed the right pathways that have been agreed through the collaboration, then hopefully we will be able and we will be delivering appropriate services for unpaid carer, refugee and asylum seekers, and they will know how to access these services. And community organisations that we are going to work with in the future in terms of upskilling and training will have the skills themselves to be able to push forward and will act as an umbrella. Next slide. So, you know, it is about improving access to well-being. Access is such a huge thing that we have to make sure we get right. And that is about the language. It is about how we communicate. Via what mode do we communicate? How we put our communication in languages that are appropriate, how we understand the community's needs. All extremely important. And we feel as though we've made really, really good headway with establishing that relationship so we can bounce on to the next phase. We've already started with our organisations in making sure that they are aware of carers, and so they can dig deeper and provide for unpaid carers as well, who are refugees and asylum seekers, with the overall result of improving health for those individuals. And that's it, finished.
Perfect. Thank you. I was just waiting for my mute to come back. Can I just say a big thank you to the two projects that have presented in this first part of the section. Really, really informative, and the storytelling I think was really important, and getting that language right. So I think that was really interesting, and I know the language comes across in different ways in all of the groups. So thank you very much. We do have time for a break. What I might do is just make it 5 minutes rather than the 10 minutes. So if we can all come back at, say, we'll start to come back at 26 minutes past. So it's 5 minutes, get your kettle on. And then when we have everyone back, we will restart the presentations for the next section. So stay in this group, please. If you just put yourself on mute, turn your camera off if you want, and then when you rejoin, if you put your camera back on, we know that we can restart. Thank you.
Good afternoon, everybody. We're just going to start the second session, if everybody's back. Jodie's having a bit of a rest now, so I'm going to take over from Jodie. My name is Caroline Cameron, and I work in the southeast of England. We have 2 further great presentations this afternoon, but once again, 10 minutes each presentation. So I'd like to get started straight away with our first presentation, and can I hand it over to Debbie and Mohammed, please?
Thank you, Caroline. I think Mohammed's on the call.
I am. If you can.
I think you're frozen, Mohammed, or is it just my Wi-Fi? I'm not sure. Debbie, are you there?
Yes, I'll take over while Mohammed gets his IT. So thank you so much. So I'm Debbie Hustings, the carers lead for the Surrey Heartlands system, and we partnered up with Mohammed Rav, and we chose to do a deep dive piece of work into improving support for South Asian carers or people living with dementia in Surrey. Next slide.
Sorry, Debbie, I am back. I don't know what happened. Great. I got knocked out or kicked.
I know you like to keep me on my toes, Mohammed. You take over now. We're on slide 2.
Oh no, I think he's got it, Debbie.
No, okay. Well, Debbie will continue. In terms of the national local dementia profile, it was really important for us to do some benchmarking at the beginning of the piece of work, so that we had a way of measuring what the impact of the webinars we held had. Surrey people don't often realise it's a very diverse county, and we have a minority carers population estimated at 20,000. I suspect that's a greater number, and 50% of those come from an Indian Pakistani heritage. So we actually estimate that there could be up to 10,000 South Asian carers. When we did a quick dive into the GP data, we actually found that there were only 16 carers of British Asian origin who were caring for someone with dementia. Next slide.
Sorry, Debbie, I'm back in. I got knocked out. So
great. It's all right. I'm going to make you do my slides, Mohammed. Over to you, slide 3 on collaboration.
Yeah, so apologies, I don't know what's happened there twice, just got knocked out. So I'm sorry I missed that first part of that, but basically we, so this was collaborative work by having experts by experience to talk through 3 webinars. The first one was around trying to have an understanding of the broader issues. The second one was to bring in an expert, so expert being the carer, and the fantastic thing there was his dad came into the meeting, and everybody that was there really enjoyed that, because we got a sense of reality really in how carers are trying to live their life, manage their work, and yet you're juggling caring. And the third aspect really was to hear from somebody who was or is a former carer, but now actually he champions having carers' voice, supporting carers to implement sort of change and decision making. And so his work particularly we were interested in was what he calls the fragmented pathway. So that's the journey really. So next slide, please. A number of issues, so we're only just really touching on this, so apologies if I have missed this, but in case Debbie has mentioned this, but there is an evaluation report that will make much better reading for people at their own leisure. But essentially there's a number of points here that we've tried to raise, and some of those particularly around things like unconscious bias that we might have, so we might mean to do well, but actually if we don't understand the needs of communities, the needs of carers, the needs of diversity within diverse communities, it makes things difficult. And the one that's more sort of pertinent, I think, from my perspective would be, and I'm sure Debbie will agree, is that we often talk about it's hard to reach, but is it that they become easy to avoid, or is it that our services are actually hard to reach? So, who's actually the hard to reach? Next slide, please. So that just sort of gives you some figures there on the side before I invite Debbie to sort of talk about some of our findings that have come through. But again, it would give you a flavour of across the 3 webinars, the kind of people we've had, from GP lead to a counsellor lead, we've done carers, former carers, current carers. So I think that whole conversation, not only fantastic in terms of the energy and the drive and the passion to actually want to make change, but it's also about being involved in part of that journey to try and get a sense of who is it that we're talking about. I mean, Debbie and I were talking earlier on how ethnic minorities has gone from ethnic minorities, minority ethnic, BME, BAME, BAME, and now we're going back to ethnic minorities. So what terminology do we use where? And it was interesting a bit earlier on, one of our colleagues on this webinar today was just talking about how they define refugees. Again, so it's about what definitions we use and how they're important to those carers themselves. So I think it's over to you, Debbie, if I'm correct.
Thank you so much, Mohammed. Yes, so if we can go to slide 7, understanding the issue. So was there change? I think that's a very important question to ask, and that's what we sought to do in our evaluation. So we sought to understand the effectiveness of the webinars and how they could be improved in the future, how participants felt they could be used to inform, educate and influence service design. And the responses indicated an overwhelming positive and the need to continue with this model of webinars as a means to engage with our carers and practitioners. Participants felt that this format enabled them to hear first-hand experience of dementia care in South Asian communities from either current carers or former carers, and to hear expert knowledge of working with ethnic minority families coping with dementia care. We also sought the views from the steering group so that the planning, delivery and review of the webinars could be included in the evaluation. And I think in terms of what we have managed to change, I think that there has been a significant shift. Thank you. We'll go to the next slide. And just wait for yeah, so this is a very quick sample slide of a pie chart that shows the before and after impact, and I think really evidence that before people attended these 3 webinars, their knowledge wasn't so great, but afterwards there was increased confidence. So thank you. Next slide. Okay, so awareness raising. So while these sessions were designed to give a flavour of the issues affecting South Asian carers looking after a relative with dementia, these small scale awareness sessions have had a direct and positive effect. Asked if there was a need or a desire for more awareness of dementia issues in ethnic minority communities, the respondents gave 100% indication that there was. Asked about any other comments from having participated in the webinars, the respondents were all of the same mind. Like Oliver Twist, they shouted with one voice, "We want more." And our Cabinet Carers lead, Councillor Alison Griffiths, has also requested we hold a separate session for members of our local authority council, which is wonderful. Next slide, please, Steve. So in terms of our participants' feedback, there were some big themes that came through all three webinars. Dementia awareness and the challenge when there is no one word for dementia in the 5 main South Asian languages. It was a key area. Information, that won't be a surprise to you. Information is also complicated if the content, including jargon, academic writing level and nuances given to words and meanings are not thought through. Migration, social influence and perceptions such as they look after their own was another theme. Other themes include stigma, the role of faith and culture. This came up time and time again, and carers telling us of the challenge they face of finding care staff who practice same faith or come from the same ethnic minority background. And finally, another theme again, which probably be very familiar with you, were the language barriers. Thank you. Next slide. So in terms of the findings of the evaluation, well, I think for all of us who had the privilege to attend these sessions, it was really essential that we check our unconscious bias. And as we joined the webinars, we park that outside the room and we come with a real open mind. And we need to keep educating ourselves, and we need to do this through listening to those with the lived experience and the importance of actually providing a safe place for those carers to share that lived experience. And we're going to need to continue to build that trust and relationship with the community. And there is a huge importance around the parity of esteem, but also the parity of a perspective for those South Asian carers. So there's a lot more work to do around the equity issue that Mohammed raised earlier. So next slide, please, Steve. In this slide, I wanted to share with you some early impact. And sorry, it's the next one, Steve, and just share with you a little bit about what's happened since we published our report. So the evaluation findings have been included in the work we've done to develop a new Surrey Carers strategy. And I'm delighted to tell you we have finally got that through the approval process of the Surrey Health and Wellbeing Board and the Surrey Executive. Very big thanks and shout out to my colleague Adam Watkins on the call, who really supported with that. And we hope to launch that at the end of July. But we're also monitoring all our carer contracts. We're collecting data on carer ethnicity, and we've done some benchmarking around those contracts. You'll remember we were talking about looking between sort of 17 to 20%, and you can see a large range there of performance. So, you know, bean counting has its place, but in this case, it really does help us identify where we need to make improvements. We need to actually support greater diversity and better representation of our communities within our carer service workforce, and all our providers have agreed now to collect ethnic minority workforce data. Again, that reads very much to that point of feedback we got around finding staff from ethnic minorities. And we've developed 11 new service specifications, one in particular around giving a voice to carers service and reaching into the community, takes into account all of the recommendations in the bigger project report that Mohammed mentioned. So in the first slide, you heard me talking about that benchmarking, about how many registrations we had with our GPs, and we have seen a shift. It's a modest shift, but we're really pleased over the last 6 months period that we have seen an increase in the wider ethnic minority carer registration, and we've also seen an increase of South Asian carers of people living with dementia registered with their GP from 16 to 74. And this is not an exhausted list, but I do want to mention our providers, Crossroads Care Surrey, who are partners in this piece of work. They deliver our home-based care break service for carers, and they're developing their own range, a standalone project of resources to promote their service to the ethnic minority community. And it's not just their service, they're also looking at promoting career opportunities within their organisation.
Sorry, Debbie, that's fantastic. I'm going to have to stop you there.
Thank you.
Really
Thank you.
sorry.
I just got to the end, so that was wonderful, brilliant. Caroline.
Thank you very much, Debbie and Mohammed. We need to move on now to the second presentation, and I'm going to ask Tim and Kate if they would like to now present, please.
Thanks very much. I wish Kate was here, but she's actually on holiday. So
right. Okay.
You just got me.
You. Well, that's brilliant. Thank you very much.
And I feel a complete fraud actually, because Jodie's in the room and she did most of the work, and Kate's not here, and Christy's already represented the project very well already. So, but I'll tell you a bit from my point of view as a commissioner of what we've been up to, and I think it links some of what Debbie was saying in terms of trying to make this stuff systemic and make sure the learning goes across the whole system. Okay, next slide, please. So at the beginning of all this, we had to work out, we're obviously incredibly grateful to NHS England for its generosity with 10 grand, but actually it's not a huge amount of money. So we wanted to make sure that it really did as much as it possibly could for us. And that meant we went through a process with the group of stakeholders, particularly Jodie, who was ringing me up about twice a day at this point, I think, looking at what would be the best way of working on this. And because of her work as the carers nurse in Lister, she was aware of some of the issues facing parent carers of people with sickle cell disease. But we were looking around also for something that would act as an exemplar to help us deliver on the sorts of changes that actually Debbie's just been talking about as well, and trying to make that go across the system. And we wanted a fairly small group of people that we could talk to. I think I'm incredibly impressed by other people who've spoken about the breadth of some of the other projects, but we really did want to focus down and make sure that the learning that we got from doing the project was spread around. And we also felt under some time pressure to get this up and running. So I think that's one of the reasons that we focused on quite a small group. When I say small, there are 135 families in Hertfordshire affected by sickle cell disease, and as you can see, quite a small and therefore perceived to be a marginalised group. Next slide, please. So as I said, Jodie was at that time the carers nurse at Lister. This was a role that we designed as part of our carers strategy, I think 10 years ago, but I can't really remember. And actually, it was quite interesting because it was funded originally by the local authority on the basis that they thought they could demonstrate to the NHS that it was worth investing in identifying carers and supporting them at discharge in particular, because readmissions would be much less likely, and that was proven to be the case. It was really important, I think, that we have a well-developed set of relationships. Carers in Hertfordshire are particularly interested. They've got some 30,000 carers on their books, but only 2 of them we found when we did the research were identified as caring for children with sickle cell disease. So there was an area that we all wanted to work on and do better on. And the Community Development Agency, the absent Kate, is the manager of this project, is also the chair of the Hearts Equality Council. So really important set of links to build on. At the same time, when we started to look at this project, I was pulling together a bid with the NHS charities and the ICS for some of the wonderful Sir Captain Tom's money. And actually, because we've been working so closely because of COVID for some time with the whole of the sector and all of our statutory partners, we were incredibly aware and I'm going to use the word BAME because that's what's written there, and that's what we were calling it at the time. But I'm desperately keen to come up with the right thing to say. As far as I can tell, the guidance tells you what not to say generally, but not what to say. But we were very clear that this group of these communities were particularly disadvantaged by COVID, obviously, and I don't think anyone doubts that, and we need to do something about that. And we were putting bids together for workers to do that, and they're now in post and they're working with colleagues across the system. And we were keen that this project would help inform them and also be supported by them going forwards as part of its sustainability. We're also doing some work with Carers and Hearts about culturally appropriate breaks and how to help carers who've been basically locked up for a year to come back out. So we're very keen that that all linked together. And similarly, we had a project around digital inclusion because it was obvious that 135 families spread across the whole of Hertfordshire, we were going to need a Zoom-based response, which is what we did, but that meant that some people might need actual support to access kit and how to use it. And as I said, sickle cell, small population, 135 families, and I think Jodie would agree that on the whole they're very happy with what the NHS is doing, but there was a huge gap in terms of what they needed from the community and the benefit system and so on. And as I said, geographically, Zoom was the only really sensible option. Next slide, please. So obviously we spoke with carers and particularly those who'd been involved in previous attempts to get a group off the ground. I think Christy said, you know, London was her previous contact. We were aware there was a project in Essex, but getting people together was very difficult because of how dispersed they were. The NHS staff were very supportive and very keen. And as I said, they felt that the medicine was generally dealt with. And in fact, there's some very good examples of consultants talking to people at schools and teachers and making sure people understood some of the issues faced by the children. But I think, as Christy mentioned, there's issues around the expertise of other parents and the need for the kind of social support and advice that wasn't available through the NHS. And clearly in all of this, if we're going to get it to work, we needed the focus of a dedicated worker with time to actually build the trust. I think I've heard trust come up several times in other presentations, and it's absolutely crucial. So even though Carers and Hearts were reaching out and the social prescribing service is there with 88 workers across Hertfordshire, building those links requires that sense of trust, and that takes time. Next slide, please. And in all of this, I think in terms of the learning, the importance of being flexible, it's great that Christy is now able to support this group going forwards, and I'm sure she may need support too in the future at some point, because there's enough for all of us to balance and juggle in these testing times. But obviously doing things in a global pandemic, I mean, it's a bit of an excuse for a lot of things, but it's actually a valid point that some of the parents were thinking, well, actually, I'm having enough trouble homeschooling. I'm fed up staring at a laptop. And, you know, life tends to intervene at times when carers want to do things. And so there are a lot of issues around people not being able to make it on the day, even though they said definitely they wanted to. And the worker, Daniela, having to reach out, try and find out what that was about, whether there are other ways of engaging. And some of that was about timing, and I believe it's moved from Saturdays to Friday evenings or the other way around. But some of it was about motivation, and also maybe there are easier ways like WhatsApp groups and Facebook for people to do some of the things they want to do, and adding things like games to the Zoom process was also helpful. Next slide, please. We were asked to come up with 3 things we'd do differently. Well, the first one is have more time and, of course, more money, actually, Neil, as well, if you've got some. But I think we could have done more with more hours for the worker and more time for the project. But actually, it's amazing that we've got to where we have, and Christy is keeping things going. And as I said, I think we want to build on that and make the learning that we've got from this systemic. I wouldn't do it during a global pandemic if I had a choice. But I do think that the sudden willingness of lots of people who were previously completely hostile to Zoom, etc., has been helpful. And I think going back for a lot of our interventions that we put together during COVID, we don't necessarily want to go back to 100% face-to-face. I'm thinking of older people who've had to take 3 buses to get to things, and you know, some of the things that the NHS has done to make it easier for people to do things remotely, some of which we want to hang on to, basically. And I think some of the sort of peer mentoring, especially with very small groups like sickle cell, it'll be helpful if people who are paired up, one from Watford and one from Hitchin, didn't have to physically get together. But those are things I think we need to look at. And then I think, you know, obviously hindsight and having listened to carers, there are things we would do differently. I've mentioned the different things other than Zoom. And obviously, this is completely obvious when you think about it, but a lot of carers said, well, what about our kids? There should be a group for them. And the importance of understanding that carers can feel very guilty if they feel their needs are being looked at, but the people they care for are not. I think we would probably a bit optimistic about how quickly we'd get to 135 people in the Zoom group. You know, the group is still quite small, but I think that's really important because it forms the kernel of something that we can really build on. But I think that role of the worker, and we can link this into social prescribing and the carers organisations too going forward, the ability to motivate people, so not just to let them drop out and disappear. Obviously they can if they want to, but be able to go back to them and say, are you sure you don't want to come back in? Are you okay? Is there anything we can help with? Is a really important part of this work. And then lastly, I think it's worth remembering that people don't know what it is they don't know. It's one of the reasons that peer support is so important, because people can say, have you tried this, or did you know about that? And people go, oh, I never heard, no, social worker never told me about that, or whatever. And I think that's a really important and powerful, and makes it sustainable as well, that kind of carers are doing it for themselves to a large extent, but we can add the support when it's needed. According to my timer, that's exactly 10 minutes.
Lovely. Thank you very much, Tim. That was excellent. We've got 3 minutes before we go back into the main area. Has anybody got a question they might want to ask one of our presenters? No? Well, that was 2 great presentations. So thank you all for undertaking the work and the great work that you've done, and hopefully
Caroline,
yes,
sorry to stop you, but Colin has got his hand up and he put a question in the chat box.
All right, okay, Colin,
are you unmuted?
I'm unmuted, yes. Thank you very much. Really interesting presentation. Thank you so much. I just wondered, is there actually now a passport for those who suffer from sickle cell? The reason why I ask is because my wife's brother died of a sickle cell attack back in the 90s. Was very much unrecognised, and he didn't get appropriate treatment from the hospital and was discharged and passed away. So I just wondered if people do attend hospital, that there is some form of system in place that it is picked up at an early stage.
Do you want me to jump in? So, Colin, thanks for that. I think got a bit of delay. We worked with the paediatric service, and it was quite small, and the families had literally direct access to the specialist nurses. So if there was any admission or any questions, they either text or called them. So that was quite quick. I think where the gap changes was when they went into adult services, but I don't know 100%. We can find out if you'd like, and we can put that in the...
Just as a point of interest, really, it'd be really interesting.
Yeah.
Also as well, just to point out another issue, my son is dual heritage, and he also has a son who is his mother's white and my son's dual heritage. and he would look white upon appearance, but also has sickle cell trait. And that was undiagnosed when my son's son was born, and was only later picked up when my son presented to them that actually, well, he is dual ethnicity and his mother is African Caribbean. So there are, or maybe, gaps in services where people, you know, young babies are picked up because of what people look like in terms of the color of their skin, for instance. I'm not sure if that has come up at all in any other instances.
I wonder if it's the way that we record ethnicity and we're not recording it correctly, because I think my understanding is that if you're from a certain, because it is ethnicity based, so Caribbean and Afro-Caribbean, that you're automatically screened. So I suppose that would be my wondering about that, and like to think that would have changed. I think, Sophie, you've got a question? Ah, there are gaps in the adults.
Yes, I'm conscious of time. I've done a lot of work in Sandwell around people with sickle cell and health and care services. There are gaps in services. Local authority care and support services, many people don't access. Discharge hospital process often isn't working for adults in particular, and awareness in hospital. So that's just in a nutshell. If it's not working in Sandwell or West Birmingham, then I imagine it's not working elsewhere in many locations as well. There's a lot of work to be done and a lot of awareness needs raising.
Thank you. Have we got one other? Is person that's got their hand raised? I can't see.
Colin, your hand is still up.
It's an old hand, sorry.
Okay, thank you. Okay, so Steve, are we going back into the main room now?
Yeah, so this is the main room. I'm just waiting
okay
for people in the other two rooms to finish, and they'll join us.
Okay, brilliant. Has anybody else got any questions? Okay.
Sorry, I was just going to say, I think it's a really interesting point about awareness raising. Given just how complicated it is raising awareness for something as blindingly obvious as families being carers and having to support people on discharge, that when you're getting down to some of these quite rare sorts of conditions, that we're going to have to be quite clever if we're really going to get that to work, I think. And I think we all need to have a serious think about that, because absolutely, if Sandwell and so on and Birmingham are having problems with it, places where presumably the numbers of people are even smaller, you know, it's going to be a complicated ask, given that we're always asking people all the time to identify lots and lots of things. So I'm not saying we shouldn't try. I think it's really, really important that we try. I'm just trying to think about how we do the learning and share the learning in a way that actually makes a difference, because it's going to be really quite complicated.
Can I just add in, Tim, the health and what you said, the health aspect of the care was fairly good. You know, it was pretty phenomenal in Hertfordshire. What they were missing was the social support, and that it was just a lack of awareness of what the voluntary sector could add to these families' care. So I think that was one of the big learnings that we had, that to use the social prescribing aspect and social support to support families as a unit.
Sorry to jump in, and to link with adult social services for care and support, and to work on the basis of trying to prevent hospitalisation and improve people's lives, and not rely on the family as carers.
Well, I've just got some stats about Pathway Zero, which we're supporting in Hertfordshire, which is people over the age of 65 going home who don't appear to the hospital to have any needs. We're finding 30% of them do.
Yeah.
And of that 30%, about 30% are likely to be readmitted if we don't do something quite quickly. So again, it's you know, it's always a problem identifying stuff at the right point.
The
So, yeah.
discharge conversations aren't fully had, it seems. Certainly in Sandwell, people are not having those conversations at hospital point. And because there are some factors around minority ethnicities and lack of engagement in the past and historically, and lack of awareness of the condition, there are barriers to overcome, similar to the presentation earlier around breaking down those barriers. So there are a lot of issues, yeah.
Just to quickly say, we've got the other people joining us from the other rooms now.
Thank you.
I think, Laurie, you had a question. You've got your hand up.
Oh, hi there, it's Laura from Carers Trust. I actually had a question for the first presenters, Carers Together. I'm not sure if they're still on this, they're still in this room. But if they are, I was just interested to hear how the project worked in conjunction with... Oh, sorry. Okay, thanks anyway.
Okay. Laura, I hope you do get an answer to your question. We will come back to you on these things. So welcome back, everybody, to the wider group. We are not experiencing Teams at its best today. I think we've all noticed. We've got sticky mute buttons, echoes, people trapped in the wrong room or trying to get from one to the other. Thank you, Steve, for sorting that out. So we're moving into the final stretch of the afternoon, and I'm going to hear shortly from Dr. Greenhow and Dr. Tickle about the main findings of the external evaluation of the programme so far. I do want to say that if you are from somebody who is interested in taking part in the next wave of the programme and you have questions, there will be some time to address questions at the end. But if you'd like to put questions in the chat, we'll get a sense around what it is you'd like to cover, and we may be able to address a few more questions in the chat, as well as highlight the key things that people want to know about. So please do ask your questions in the chat if you have them. We'll come to that after hearing about the external evaluation and from Bola Awolabi, the Director for Health and Equality at NHS England. So I'm going to hand over now to Dr. Greenhow and Dr. Tickle for a sense around what did you find from the external evaluation. Thank you.
Hi everyone, hopefully you can hear me. Thanks for having us today. It's been really interesting to hear some more from the sites in relation to reflections on the project and what they have been finding and sharing and learning. So what we would like to do today is just to give you just a flavour really of some of our main findings from the external evaluation, and there'll be more detail in the report that we're producing that will be circulated in due course. Okay, so next slide please. Thank you. So just a little bit about our approach to the evaluation then, and how we undertook this. So we evaluated 3 of the sites, so 3 of the projects that were involved in Mind the Gap. So we focused in depth on those 3 case studies, which are listed on the slide there. And these were selected, the 3 sites were selected through consultation with NHS England representatives based on a number of things around practicalities, the potential to add value to the evidence base, and also that our external evaluation wouldn't risk any relationships that had been developed through the important scoping work that had been undertaken in these sites. So we ended up with 3 sites, as you can see there. The case study A, so engagement, co-production and consultation with young adult carers. Case study B, ethnic minority carers who are looking after a loved one with a learning disability in West Birmingham, and case study C, BAME carers in local practice in Doncaster. And this was we've had some discussion today around terminology, and this was the terminology that was used at the time of the projects. So following the selection of those 3 case studies, we worked closely with the project teams to find the best way to proceed with our evaluation in a way that was culturally sensitive and did not risk any of the work that was already undertaken. And in all sites, it was deemed appropriate for the project teams to identify and contact carers initially to take part in our external evaluation.
to ensure that there was a warm handover and any practicalities and support needed for carers was in place, such as translators. So the methods that we use, and just really briefly, and there's more detail of this in the report that'll be circulated. So we took a qualitative approach for our evaluation and spoke to a small number of carers from each of these sites in depth to understand their experiences of the Mind the Gap project. So we undertook interviews with 4 young adult carers in case study A, and that was online via Zoom. In case study B, we had 4 phone interviews with adult carers, and then in C, we carried out a focus group with 10 adult carers. Okay, so that was just a brief overview of our approach. So I'll pass over to Sarah now. Next slide, please.
Thank you. So what you can see on the screen there is some of our key evaluation research questions. So within our qualitative interviews and focus groups, we did ask a variety of questions, but they mainly focused on these key evaluation ones. So you can see there that what we were interested in is obviously in terms of participation, in terms of feeling listened to, and that it was a meaningful experience, exploring different ways in which to engage with carers in the future, and obviously most importantly what matters most to carers moving forward and what they hope to see happen as a result of the Mind the Gap projects. Next slide, please. So from the questions that we asked from all of the sites, we then collected the data, it was transcribed, and then we conducted thematic analysis in order to explore some of those, key themes from the findings. So what's on the screen there is a bit of an overview of some of the key themes from each site, but obviously these are much more detailed in the report, and obviously they relate to some of the key learning points that we're going to talk about next. But as you can see, a common theme that was found obviously across all the sites was that the engagement work that was taken on from all of the case study A, B and C was that it was a positive, rewarding experience, that carers felt empowered, felt listened to during the project, and also it consolidated and focused on existing support as well for the carers. So we also had discussions around in terms of what was best in terms of participation, so exploring digital and face-to-face engagement, and also in terms of what matters most to carers moving forward. A common theme across all of the sites was this real hope and this real need for change. So therefore, some of the discussions were quite personal and obviously quite specific to some of the case studies. But overall, the carers wanted hope for change and wanted things to change in the future. What matters most moving forward in terms of what they wanted to see happen as a result of the Mind the Gap project, alongside this hope for change, did vary across sites. Obviously, specific responses for specific sites because of the communities, but overall, raising awareness was a common theme across all sites. Improvement to the GP service in terms of breaking down language barriers, in terms of flexibility in appointments and things like this. But also a common theme across all sites was to improve services in terms of the connectedness of carers within organisations and also caring organisations and other health service providers. So that's just to give you a brief overview of those key themes. We haven't got enough time today to obviously go through every single one, but we'll talk now next about some of the key learning points from each site, which obviously relate to these themes. Next slide, please.
You're on mute, Sarah.
Thank you, sorry. So in relation to case study A, then some of the key learning points that we found and what was common, as Sarah said, across all of the sites that we spoke to was that the carers found taking part in Mind the Gap a positive, rewarding and empowering experience, and they felt that they were part of a development of services, and this was something that mattered to them moving forward in relation to seeing the outcomes of the Mind the Gap project. We focused on asking around their experience of taking part, and no major challenges were raised in relation to participation. So that was a real positive, and any minor kind of challenges were mitigated by the way that the project was managed. So all carers felt comfortable taking part. They also felt listened to during the project, and it consolidated and focused the existing support that they were receiving, and allowed them to focus in on a particular issue that was important to them, which is the transition to adulthood. In terms of moving forward and engaging with young adult carers, hopefully when COVID restrictions are lifted, there was some preference for face-to-face discussions to return, but also some value in maintaining some digital engagement, which we've heard from other projects who've spoken today as well. And there was some discussion of a group kind of discussions being valuable moving forward to share experiences with peers as well. In terms of the what matters most moving forward was the real outcomes that they could see. What they wanted to see was real outcomes stemming from the Mind the Gap, and this made their experience more meaningful for them because they could see that this was beginning to happen with their project. So it made that engagement really meaningful for them, and particularly the issues that they were particularly interested in seeing moving forward was professional awareness of carer role and needs across education and health, implementation of a transition passport to share understanding across professionals, and also ongoing consultation moving forward with young adult carers. But what we found across all sites and is highlighted here is that it was clear that the Mind the Gap project in this site measured what mattered most to the young adult carers that we spoke to, and we could see that what was being raised with young adult carers with us was represented in the report produced by the site and the case study. So it confirms, that what was being measured mattered most to the young carers. Okay, so I'll pass over to Sarah. Next slide, please.
Thank you. So as you can see from case study B, in terms of speaking to carers, and these were on telephone interviews that we did, as we've already said, it's a positive, rewarding, empowering experience for the carers that participated. There was no major challenges to participation within those phone calls, and they did feel listened to and consolidated and focused their existing support because they were existing users of the caring organisations. Due to obviously COVID restrictions, they would prefer face-to-face. However, they did actually like the telephone interviews because it fitted in with their other caring responsibilities and other commitments, and felt that it was flexible and accessible. So moving forward, they still didn't mind this kind of engagement work. And again, in terms of moving forward, the carers reiterated time and time again this hope for change, for these real tangible outcomes, particularly in terms of wanting to see some tangible outcomes in terms of this connected and continued support. So between different caring organisations within the area and also nationally as well. What was also really important was raising awareness and support, opportunities for respite as well, and also all carers that we spoke to, there was a lot of importance given to their own well-being as well, and helping carers to receive support for their own, complex, often complex needs too. Talking about the GP system, and again, there was lots of recommendations by carers and ways of moving forward, how simple little tweaks could help in terms of breaking down barriers and in terms of flexibility with appointments. So again, as we've said, it's clear from evaluating case study B that it did measure what mattered most to the adult carers, looking after a loved one with a learning disability and living in West Birmingham, and this was also represented in their report. Next slide, please.
Thank you. So I'll run through this case, the key learning points from case study C, quite quickly because I'm conscious of time. But there's some real key overlaps, as you can see, developing across the 3 sites. So again, it was the carers found this a positive and rewarding and informative experience as well. So there was some information sharing within the focus group that took part, and they found that really useful for them moving forward. There were some challenges to engagement in this site, including language barriers and struggling to use the technology that was being used as well in terms of Zoom. So that was an ongoing kind of struggle at the time that we spoke to carers. Overall, the carers felt listened to and that their voice was heard, and particularly for carers in this site, they felt that they weren't listened to before engaging with the Mind the Gap project. So they felt that they were being asked questions that they hadn't been asked before, so it was really valuable and meaningful to them. In terms of engagement, there was a real preference for face-to-face discussions to return. There was no doubt about that in this one, that face-to-face was key for them moving forward. And again, what was really important across all sites was this hope for change and bringing real outcomes as a result of Mind the Gap. So it's really interesting to see and hear, and really important to hear about phase 2 of the projects in the next year. But the real outcomes for this group that was important was the consistent use of the carers register, improvement of the GP system in relation to breaking down language barriers and improving access to GP appointments, and also consistency of GPs, so that they were always seeing a GP that knew their background and their story. So in relation to what was measured by the report produced by the site, again, it was clear that what was measured by the site was what mattered most to carers, but they also raised a couple of extra specific additional points in our evaluation around the consistency of GPs and also improving access to appointments, which was something that seemed additional. Okay, so next slide, please.
Thank you. So what we're trying to do on this slide is obviously pull together some of those key themes and key common learning points that we've just been talking about. But I think due to time wise, I'll move down to the bottom 2 points, because we've already talked about some of these really important common themes across all sites. So it was clear from the evaluation that all of the sites A, B and C measured what mattered most to their carers, and this was reflected in the report, and which will be also reflected in ours as well. And I think the most important thing for all carers was not having to repeat themselves and to tell their own, tell their story again and again through different mechanisms and with different healthcare providers. So in terms of reflecting on the evaluation, I think what's so important, which has obviously been related and discussed today through all of the project overviews, was that this isn't a one-time exercise. Real outcomes need to stem from this, that there is tangible visual outcomes from all of the projects, and that real change and improvement has to be made. It was clear that it was meaningful and positive for all carers, but this needs to be maintained, and specific outcomes for each community need to be considered. So in this recognition of this hope for change, and to continue that it's not a tick box exercise, and hopefully the new second phase that's been discussed today and launching that will be able to address this and implement what matters most to the carers that we spoke to from all of these 3 sites. And lastly, in terms of recommendations, we're going to have quite a lot of them from all sites that we're going to put into our report. But I think the idea of the co-production of outcomes, should be built into the project. design across all sites from the beginning of any project, in terms of developing these and it be meaningful for carers. And in terms of thinking about ways to, in the future, obviously to engage with carers, there is lots of different personal preference. Obviously we all want face-to-face to come back to return, but we've all adapted, and some carers do have personal preferences, so it's obviously bearing those in mind and seeing when we move forward it doesn't always have to be face-to-face. We have got some other alternatives as well. So as I say, a quick whistle-top store there, but all of this will be in our report that will be circulated to you all. So thank you for that. That's the last slide, I think.
Great, thank you very much for sharing that. And as people have asked, and we've been told, the slides will be shared, and indeed the videos will be shared afterwards. So we on the final closing remarks now, we're joined by my colleague Dr. Bola Owolabi, who's NHS England NHS Improvement's first ever Director of Health Inequalities. He will be very interested in this discussion and how it fits with her wider agenda. So Bola, over to you. Just before I ask you to speak though, just please do, if you have any further questions about the programme, please do put them in the chat. I don't think we're going to have time to take them afterwards, but we will answer questions that are put in the chat. So please do continue to ask those questions. But Bola, over to you.
Thank you so much, Nick, and for that very kind introduction. Hello, everyone. Nick has kindly introduced me, but also to add, I work as a GP in the Midlands, and the conversation that we're having today has particular resonance for me, particularly from a professional point of view. The discussion around carers. And I know that quite often when we have the discussion about health inequalities, we do think about individuals themselves and our communities. But, reflecting on my work clinically and listening to the discussion that has happened here today, I recognize that we do have an opportunity here to reframe our conversation around health inequalities in a way that includes carers, because often they are off the radar, not because anyone proactively goes out to exclude them, but there is a danger that if we're not deliberate, if we are not proactive, and if we are not explicit in drawing them to the fore, then there is the danger that we miss them out of our narrative. And prior to starting in this Health Inequalities Director role, I was National Specialty Advisor for Older People and Integrated Care. And I remember developing the anticipatory care model. And a fine gentleman who is a governor in a trust where I worked, I just asked his advice and said, can you have a look at this model? And he looked at it and said, Bola, I can't see the carers in it. And if you don't put the carers in it, all your best laid plans will come apart if and when the carer keels over. And that statement has never left me, because carers across the country are holding the ring around so many individuals. They are the unsung heroes, actually. And all our best laid pathways, all our best laid care plans will come to naught if the carer keels over. And so I think as we talk about health inequalities and how we are going to narrow the gap on health inequalities, it becomes ever more pertinent that we think about those communities that tend to be at the margins. So our most deprived communities, the people in that bottom 20%, when you look by the index of multiple deprivation, that most deprived 20% of our communities, where they lack many things, but they don't lack community and they don't lack heart. And I have done many, many home visits in my time as a GP, and I never ceased to be amazed by the resilience in people's lives. A lot of the resilience brought about by individuals in their lives, quietly providing care, most times unpaid, actually. And I do think by focusing on that bottom 20% of our population, we will discover health inequalities not just for individuals themselves, but necessarily affecting their carers. Also, if we look at the ethnic minority communities, it's a community that assumes the caring status almost by default because of cultural reasons. And again, I think if we lift the bonnet on of that, we will find a lot of inequality and difficulty in those communities. Then if we turn our focus to people who lack agency, people living with learning disability and or autism, those living with severe mental illness, those living with dementia, there is a new order of burden and stress that is brought about by those particular conditions. I used to chair a system continence group, and we were drawing a whole system continence pathway. And I remember the chief executive of Age UK for that locality, who was on my steering group, saying, Bola, you do realize that we have a safeguarding dimension to this conversation. And I said, what do you mean? She said, most carers can cope until people become incontinent, whether urinary or double incontinence. She said, you cannot believe the pressure that brings on a carer. And I know there are many people across this country looking after relatives or friends living with dementia who are troubled in this way. And so as we go forward in this worthy cause, my plea would be that we particularly look at those communities, those carers in that most deprived section of our community, those from the ethnic minority communities, those with learning disability, those with dementia, those with severe mental illness. And can I just remind us about the inclusion health group, the people who don't even make it onto our data sets, our traveller communities, people experiencing homelessness. Let's not forget them in the conversation, because many times when we talk about population health management, these communities don't even show up in the data and they are in danger of being forgotten. So thank you for the work that is going on in this space. I think it truly is extraordinary. But if you would kindly consider the dimension I've suggested, I'm sure that our people will be grateful and it would make a huge difference in narrowing health inequalities. Thank you.
Fantastic. Well, some wonderful words on which to conclude our afternoon. That's, I think, been a really good description of projects that have already made a difference, and some further challenge and inspiration to go above and beyond that for the future. Verity, I just wanted to call you in briefly at the end if you wanted to say anything about what happens next. I'm conscious that there's been quite a lot of conversations in the chat, and we've got just a couple of minutes, I think, to draw a conclusion.
Absolutely. Firstly, thank you everyone so much for being involved and presenting all of your wonderful work. So next, what happens is we will share with everyone the bid document for this year if they want to be involved, and we will produce a Q&A based on the questions and comments in the box. I don't know if there's been a great deal, so we might also share last year's Q&A because there might be things that come up more kind of commonly about this work. And then there will be, I can't remember the deadline off the top of my head, but we'll include it in the email, and then we'll have a review process for the bids, and people will know the outcome by August in terms of the bid process and how they've gone. And I would just echo what Bola has said in terms of thinking about the communities who were less represented this year. So we've got all the case studies on the Futures platform, and we have had some refugee and migrant case studies and work this year, and some Roma Gypsy communities, but there was kind of a gap in terms of armed forces and veteran carers, and also people who are dependent on alcohol and substance, who are dependent on alcohol and substances. So it would be wonderful to hear from some integrated systems who are working with carers for those individuals as well.
Lovely, thank you, Verity. And I think people have got about a month to respond, but so we will confirm that in the paperwork. But if you've missed anything today, because obviously it's been a bit bumpy on Teams, do go back. The videos will be there and the presentations will be there, and we're really looking forward to building on this and moving forward. So thank you very much for joining us this afternoon, and thank you so much to everybody who's presented and shared your work with us and the learnings from it, and thank you, Bola, for joining us too. So thank you again, and look forward to seeing you at a future Mind the Gap session. Thanks everyone.
Thank you.